In this lecture, we're going to talk about Cauda equina syndrome. We're going to discuss some of the red flags, some of the red herrings, some of the problems with diagnosing and assessing. And ideally, we're here to give you a direction to what Cauda equina is, and hopefully you can formulate your way of examination. So, to put your mind at rest straight away, Cauda equina, albeit a very serious condition, is rare. Happens in about 2% of all herniated disc cases. Its innervation, which is from T12 to L2 after the conus, innervates the lower limb, sphincter saddle, bladder, and distal bowel. Now, Cauda equina syndrome is as a result of functional loss of 2 or more of the 18 nerve roots that comprise or make up the Cauda equina. This is why we need you to effectively go back to the questions in the previous lecture, revisit those, because a lot of those questions, if positive or you have an outcome, may point to Cauda equina. If surgery is not performed at the right time, the outcome can be poor. And about 20% of patients have poor outcome once they get to Cauda equina syndrome. This is why we need you to be asking these questions and looking at the global aspect of the patient. They can end up having colostomy bags and experience psychosocial issues with issues of going to work, movement, chronic pain. So ideally, we need to make sure that you are asking the right questions and referring at the right time. Now, this is a rundown of a list, not exhaustive, but of some of the fairly accepted signs and symptoms or warning signs of Cauda equina. If any of your patients suffer these, it is an immediate referral. Ideally, they need to be seen within 12 to 24 hours. Now, this can differ for different practitioners, whether you have direct or indirect access. Either way, a good bit of information to the patient of what you think may be going on, with effectively sending them potentially with a letter, but not overly describing what you think the problem is, because remember, the patient will probably open the letter and read it. But if you can get to speak to the doctor you're referring to, whether that be the GP or a specialist, and you can convey your concerns to ideally make sure that that patient is seen fast. As we said, the patient needs to be seen within 12 to 24 hours. Now, the downside to Cauda equina syndrome, there's no widely agreed definition of a diagnostic criteria. You'd think there would be, but there's not. And at the moment, there are approximately 17 different definitions. This is extremely unhelpful. But you can understand when the initial signs and symptoms are subtle and ambiguous, it makes it very difficult to diagnose. And the information that we learn as students can also be extreme red herrings, such as stress incontinence, pain. That's never on its own an indicator to anything. Conditions like BPH can be a red herring. Erectile dysfunction can happen for many reasons. These are all signs and symptoms, and this is why you need to ask the right questions at the right time, employ the right tests at the right time. And this is why, if you need to, at this stage, you can go back to the previous lecture to run through those questions. Ultimately, if you need to refer the patient as quickly as possible to the next person above or the right type of specialist. Now, you need to appreciate also that some of the symptoms may be as a result of medications. Now, this section here is not here to bash medications at all. They have their place, and used in the right way can have great effects and positive outcomes for the patient. What we're saying here is you need to be aware that if the patient's medication has been changed, whether that means it's new or it's been added or it's been lowered, any change and change to their symptoms needs to be readdressed by that prescribing doctor. So if that has happened, this information should come out again in the history. Have you changed any medications? Has anything been added, taken away, adjusted, changed brand, changed name, changed type, anything? And if that means with any of that, that their symptoms have changed, that is a referral back to the prescribing doctor. When we say sexual dysfunction, we don't just mean the classics for males or females. It could be any that we list here. Vaginal anesthesia, numbness, incontinence during intercourse, problems with orgasm, erection, ejaculations, any of this aspect. And these are very difficult questions to ask. They need to be done in a sensitive way, but fairly direct. And again, if the patient doesn't necessarily answer the questions, you need to leave the questions effectively open that they can return next time. And again, you should be asking of any changes at each appointment. So it's overall, even though there's difficulty in diagnosis, we accept that one of the following should be present to make a provisional diagnosis. These effectively run with red flags: a sudden change in bladder and bowel dysfunction, sexual dysfunction, and reduced sensation in the saddle area, including most of the glute area or buttocks. Okay, this is extremely important. And this is, again, if you need to, go back to the previous lecture. Now, as we said before, there are different types of Cauda equina, and this is effectively what they are. We have Cauda equina syndrome suspected. Very, very difficult. They may just come in with back pain, bilateral radiculopathy, subjective sphincter problems, and perineal problems. Now, effectively, the red flag here is the bilateral radiculopathy. If they have bilateral symptoms, that is a red flag. It could be indicative of what we spoke about in a previous lecture of cancer, but it obviously could be Cauda equina. Again, go through the case history and see what the relevance there is, but any bilateral radiculopathy should be observed by a specialist as soon as possible. Then you have CESI, Cauda equina incomplete. Same signs and symptoms as stage 1. There's an objective decrease in sphincter control. There are bowel and bladder changes, and they have the saddle anesthesia that we spoke about in the previous slide. This is an emergency, potentially surgical, and again, it comes back to the 12 to 24 hours optimum to have a greater chance of a full recovery. Then we have CESR, Cauda equina retention. Complete loss of bowel and bladder, neurogenic retention, and poor prognosis. I would like to say that it's very unusual in a sort of private practice setting that you may see this, but it's not impossible. So if the patient is phoning you to request an appointment, they should be screened over the phone for things like Cauda equina, and those questions again come into play. So again, you can at this stage revert back to that. Overall, the timing of a surgical intervention is widely disagreed among researchers. However, like we said in the previous slide, 12 to 24 hours seems the optimum. So again, this needs to be quick, and your channel of referral needs to be open and functioning. Now, this usually begins from the onset of urinary or bowel dysfunction and has poor prognosis if going over the 48 hours. Comes back to ask the necessary questions, recording them is not only necessarily from a medical legal purpose, but it also assists you on further appointments. So again, if you haven't asked the question and you haven't written it down, it never happened. It's very, very important at this stage through any one of these types. The type that you will probably see in your clinic would be type 1 and type 2. If you work in a hospital setting, you would be more accustomed to seeing type 3. Now, I've already spoken about this, but a development of an early toolkit would be absolutely paramount. And we call for this so that essentially what we are saying, it doesn't matter whether the patient sees an osteopath, a physio, a chiropractor, a manual therapist. We should all be working effectively on the same criteria. And unfortunately, we are not. So it comes back to, if you are using the right questioning, getting a good case history, there should be no problems, and you should be covering any patient you suspect that has a red flag and you suspect Cauda equina to be referred within that 12 to 24-hour period. But a good idea from a patient point of view, as we've spoken about clinical expertise, but a patient point of view that presents potentially with these types of symptoms should maybe be given a CES card that effectively tells the patient if they have a development of said symptoms, such as bowel and bladder, bilateral radiculopathy, then they would be able to take emergency intervention themselves to refer, more likely going to A&E. So as a overall conclusion, if you suspect Cauda equina, the patient needs to seek early diagnosis, early intervention within the first 12 to 24 hours. The patient needs to be screened thoroughly and explain the importance of these questions. If you find several red flags, refer. And ultimately, the urgency of the situation would need to be reiterated to the patient, but reassure them appropriately without causing anxiety. It can be difficult in these cases. However, it's paramount that you obviously remain clear and professional and keeping good dialogue with the patient. But overall, we would like an overall criteria that all manual therapists work from.